Hi, we're back live with our fibroid program. February's Fibroid Awareness Month. I'm Dr. Michael Moore. This is Donis Moore, my wife. And she is a little worn out today. She had to go in for jury duty this morning and fortunately didn't get chosen. So we have her here with us tonight instead of being sequestered in a hotel room for a murder trial. So, this is the third installment of our Fibroid Awareness Program, and if you just tuned in, so we want to kind of share some information about fibroids and what can be done with fibroids. We've had great questions in our earlier part, and in our first hour we had one of our patients who shared her story. She, like a lot of other women, had a fibroid procedure. The fibroids came back. She had another fibroid procedure, but the second one was even less invasive than the first one, and we'll talk a little bit about those technologies. First thing I want to do, though, is just talk a little bit about what are fibroids. Quickly, we're going to put up what's called slide 2, and it kind of shows uterine fibroids. And there's basically a simple classification for fibroids, which are submucosal, interstitial, and subserosal. Submucosal fibroids mean they arise near the uterine cavity, so basically on the inner third of the muscle wall of the uterus. Oh, real quickly, a fibroid tumor is a muscle tumor. The uterus is a big muscle, and a single mutation of a uterine muscle cell turns into a fibroid tumor and they can grow. And if that cell is close to the uterine cavity, that fibroid grows into the uterine cavity, causes heavier periods and bleeding problems and cramping issues. But they generally do that when they're small, so they're harder to diagnose, and ultrasound is incredibly important to do that. Interstitial fibroids arise right in the middle third of the wall of the uterus, so they have to grow quite large before they start causing bleeding problems. And then subserosal fibroids arise close to the outer surface of the uterine wall, kind of on the outer third. And those are the ones that grow out, and they don't tend to cause bleeding problems. So usually they're the ones that are found later when they are fairly large, and that's the case where the woman just thinks everything is great, goes in for a pap smear, and all of a sudden the practitioner gets big eyes about, starts telling her about her big uterus that's the size of a grapefruit or something like that, and ultrasound then reveals a fibroid. And some women have multiple fibroids, and so I've seen women walk in with 10, 20, 30, 40 fibroids. The most I've ever taken out was 64, and it's just incredible how many there can be. And then treatment for fibroid, we're going to just, fibroids are the single most common cause for hysterectomy in America. About 30% of hysterectomies each year are done as fibroids as an indication. But when women come to us, we talk about all options for fibroids. And we're going to go to slide 4, which kind of talks about ways that we can help with fibroids. And our patient Joan earlier talked about how when her fibroids weren't as big and weren't as symptomatic, things like birth control pills, progesterone, the progestin IUD, these are things that can kind of help control the symptoms. And as we were discussing a little earlier, the idea is if we see the fibroids early and they're small, medical management can kind of help, but eventually they're going to grow, and the idea would be to kind of get them at the right time. When they're not too big, they're causing problems, the medical therapy may not be working as well. It's when they're great big that they pose a greater risk for surgical complications. And unfortunately, surgery is really pretty much the only bottom line way we can take care of fibroids. There is no pill that you could take for 10 or 20 years that wouldn't have some other negative effects on your body. But again, small fibroids can be treated more conservatively. And then when we get to surgery, we talk about what are the things that we can do. And hysteroscopic surgery, using a tiny scope to go through the cervix, doesn't require any incisions. And when fibroids like the submucosal fibroids are causing problems, and there's maybe no other fibroids around, or the other ones are small, if we just go through the cervix, use that scope, the woman wakes up the next day a little crampy and a little hungover from the anesthesia, but it's the second day the woman wakes up, she's ready to go back to work, she's recovered from it, and most women return to their normal activities in 2 to 4 days. And sometimes we do what's called endometrial ablation along with removing the fibroid, because we're there, and if the woman's completed her family and she wants to stop having periods but is not ready for the pain and recovery of hysterectomy, this is a procedure that's to women is the same as hysterectomy. I'm not bleeding anymore. We do the resection ablation. That is the gold standard of ablation. So when somebody says we're going to do an ablation, ask them what kind. And if they say a thermal balloon or a Novasure, those are good, but they're not the gold standard. The gold standard is the resection of the entire uterine lining. And then we get into laparoscopic surgery. Now, women who've had open abdominal surgery would tell you that laparoscopic surgery, which involves 4 small incisions, is way less painful. In fact, they'll tell you that the pain and recovery from a laparoscopic surgery is like a walk in the park compared to their open abdominal surgery. And we can do a myomectomy, just take the fibroids out, not do a hysterectomy. Even if a woman doesn't want to have children, some women just aren't ready to have a permanent procedure, a hysterectomy. When a woman is ready, we can do a hysterectomy, but when she's not, we can just take the fibroids out. And I've done a number of procedures where the woman really didn't want a hysterectomy. She just wanted the fibroids out. She wanted the ablation, so we can do the 2 of those together. And then the most exciting technology to me in the last 20 years is the Sonata procedure. We were lucky enough, Donis and I were lucky enough to be invited to participate in the North American trial. So we got to apply this technology, use this technology before anybody else in the United States. And what the technology involves is putting an ultrasound probe directly inside the uterine cavity. So brand new technology, never been used before. And when you put an ultrasound probe directly inside the uterus, you can see even tiny little fibroids. Then with that ultrasound probe, we're able to use that to guide a needle into that fibroid. And then the needle has other little needles that extend out from it. And it creates a sphere of tissue destruction. We call it radiofrequency ablation. I like to call it zapping. And we zap the fibroid. And it doesn't shrink tomorrow, but over the next few months it shrinks down, the symptoms go away. But what is so cool about this technology is, again, we're going through the cervix, we're not going through the abdominal wall, so the pain and recovery are a fraction. And this is ideal for those small fibroids early instead of waiting around until they get to be big monsters and require an abdominal approach. And even though we can assure our patients that our track record is 99+% likely we can do a myomectomy or hysterectomy laparoscopically, this has the potential to even reduce the number of those laparoscopies. So very exciting technology. It's going to be available very soon here in Denver, and can't wait for it. But again, to kind of recap hysteroscopic surgery on slide 5, a hysteroscope is a scope that goes inside the uterus. We use a little tiny one for diagnosis. We use a bigger one with a loop electrode to take out the fibroid. And the series of 3 pictures at the bottom shows how that loop electrode can cut off a strip of fibroid tissue and it can be removed. And that's great for the submucosal fibroids, the one that's in the cavity that's shown in the diagram. The one just below it in the diagram to the left shows one that we can also remove. But when you look back at that slide 3, that interstitial fibroid isn't one we're going to get to with the hysteroscope, but we could get to it with that Sonata needle. And so that's the kind where I can treat more fibroids without having to resort to laparoscopy or a hysterectomy. So it's a great technology. And then there's laparoscopy, which is shown on slide 8. So you don't need a 6-inch incision across your abdomen to do your surgery. If you come to the Advanced Women's Health Institute, I can tell you 99% likely plus that we can offer you the procedure where we put in the 5mm trocar. 25 millimeters is an inch. So you're looking at 3 ports that are basically 1/4 of an inch, something the size of a pencil. 12 millimeters is a 1/2 Add your incisions up, you have 1 1/4 inch of incisions, not 6 inches. And we can use it for all aspects of care, not only fibroids and hysterectomy, but treating endometriosis, ovarian cysts. There's a lot of things that don't require open abdominal surgery anymore. You just need to have the ability to do those. And being fortunate enough to have the training a long time ago, there's not a whole lot that I haven't been trained to do. So we can offer the least invasive, least painful approaches. And then slide 11 kind of shows you a little bit about the Sonata technology. It's a computer and ultrasound-based technology. It's smart technology. When we put the needle in, we now then see a circle, two circles, one's red, one's green. The red circle is the ablated area, so we want that to be the size of the fibroid, so we destroy the entire fibroid. The green zone tells us the safe area, and so we always have to keep that green zone within the uterus, so we double check it. Now, that is a little of the limitation of the technology. We can't put that green zone outside or we might harm the outside tissues, so we really have to be careful about what we can do. But to do a laparoscopic myomectomy, as we were sharing with Joan earlier, our studies that were done by our fellows in our fellowship program, 25% of women, even though we were really good at getting all the fibroids out, 25% of our patients still had at least one residual fibroid. They were usually small, maybe 1 centimeter, and they were the interstitial kind. So they were kind of right in the middle, not close to the outside, not close to the inside, and we just couldn't find them. Now I have a way of not only doing the laparoscopic myomectomy, getting rid of the grapefruits and the oranges and the watermelons, but those little tiny ones that are the size of gumballs and M&Ms, we can treat those with this this radio frequency needle. The next slide, slide 12, kind of shows how the ultrasound probe is there, and then out of the tip of the ultrasound probe is the big needle, and then the little tiny needles coming out. It's incredible technology, and we're so excited to be able to offer that. One other thing that we offer is the ability to access FDA studies. There are many companies that are trying to develop medications so that it would be possible for a woman to avoid surgery altogether, and we're constantly looking for ways we can help our patients. And one of the ways we can help our patients is if you don't mind keeping a diary, you can get a medication that otherwise would cost thousands of dollars. All your care is free. You get a little bit of a stipend for your travel time and your inconvenience. And I'm going to ask Donis to chime in real quick and tell you a little bit about our fibroid studies. I'm going to turn it over to you, dear.
Thank you. Well, in fact, I've just been working earlier this evening on the Investigational Review Board periodic review. So all of the studies that are FDA approved also are approved by an investigational review board. So every year we have to give them an update. So I have to tell them how many patients I've consented, how many adverse events that are reportable that we've had, how many screen failed, how many lost to follow-up. So these are things that when you do participate in an FDA study that you have to keep updating every year. We always have to update Dr. Moore's medical license, his OBGYN certifications. So anyway, you have to keep all of that updated. So that's what I've been working on earlier today so that we can continue to enroll in our Primrose study. So this is our major fibroid study right now that we are enrolling in, the one that I was just doing the periodic review for. And so you have to have a specific size or a certain number of fibroids that make the uterus a certain size, and Dr. Moore determines that when he does your ultrasound when you come in to qualify for this study. So you don't have to have fibroids, a diagnosis of fibroids to come in and screen for one of our studies. The first thing we have to do is go through that informed consent, and Janine is my fellow study coordinator, and so it takes us about 45 minutes to go through the consent. It's not all just consenting. The first part of it they call just patient information, so that you understand what the study's about, and then you'll sign that after all your questions are answered, and you'll also get a copy of that signed consent, so you can always refer back to that at any time. In that consent, it will spell out to you what's going to happen at every visit once you're in the study, what the screening tests are that you have to have. So you'll be getting, ultrasounds, pap smears. We also do endometrial biopsies. We want to make sure that there's not any cancer inside of your uterus that's causing your bleeding. That if you do have fibroids, that it is indeed the fibroids that are causing your heavy bleeding. So there are blood tests that we do. We'll check thyroids. Every study is different as to the tests that they have, but you'll be receiving a lot of medical tests, and you're certainly welcome to have any of those results to take to your primary care physician or your internist, or just to have for your own records. So the the Primrose study has an e-diary that you'll fill out every day, and it does seem to be that some patients have a hard time remembering to fill out their diary. It has an alarm on it, so it should remind you to fill it out, and I usually just suggest that patients, put it by your bed at night before you go to bed. You usually set an alarm clock or whatever, just enter the information. They want to know if you've had bleeding, what your pain level was, if you've taken any over-the-counter medications for the pain.
So it's only a few questions, right?
It's only a few
questions. It takes more than 10
questions.
minutes to fill it out?
No, I would say maybe 5 minutes.
Right, so 5
or
minutes
less.
a night,
5
just
minutes a
did you
night.
bleed, did you have pain?
So,
Yeah,
but the
that's just
important part of the e-diary too is that there's questions in there about your bleeding and your outcome, and so that is a big endpoint for the study, for the sponsor to gather the information. It used to be all paper questionnaires, and I would have to set up the computer and enter all those questions, and then my monitor for the study would have to make sure that I entered the data correctly. So in a way, it's made it slightly easier for the study coordinator and the study monitor, because now you're entering a lot of that data. There are still some paper questionnaires, but you enter a lot of that data yourself on certain visits. So they have the data without having to go back and check to make sure I didn't click on the wrong box when I'm entering data.
And next week we are going to have a patient who is one of our past study patients who's going to come in and share her experience with everyone. And she was kind of sad when the study ended, because I think she would like to have stayed on it a lot longer, and she was very fortunate. She had medication for about a year and was very, very happy. And so Michelle will be on next week, and we'll talk about that. Didn't mean to interrupt you, dear.
Oh no,
but I did want to put in a plug while you were talking about it. Anybody that has heavy bleeding, or if you know somebody that has heavy bleeding, and it's kind of like, maybe do you have fibroids or not, okay? And this is like, you don't have to have insurance or anything. We are offering free exams next Saturday, the 23rd, from 9 to noon, and longer. If everybody fills up those slots, we'll stay here. We want to help our community, and a lot of women with heavy bleeding don't necessarily have fibroids, but those with fibroids, we want to make sure that they know about the study, know about their options, and it's something that we're doing to give back to our community because of the great work and the great opportunities and the education we've had about fibroids, and we want to try and help to make sure that women know the best possible care they can have. And so yes, we'll be here Saturday, and if you know somebody, tell them, call us, sign up. We'd love to have you come by and learn more, and kind of a little open house to tour the facility and see what we're all about.
Yes, and one of the studies, it's the Bear Fibroid study. And one of the questions that we ask at their follow-up visit after they've completed the treatment is, would you rather try another medication? Would you rather stay on this medication? Would you rather have surgery? Would you rather do nothing? And I would say 100% everybody says, I want to stay on this medication if I could. Now, of course, the study's limited. It's either usually in a year or 2 years for most studies. And, but it's encouraging that patients tell you, yes, I want to stay on the medication. So we know that the side effects aren't that bad, that it stops their bleeding, and they're much happier because they don't have to plan their life around their heavy bleeding. So that's our one of our fibroid studies. Just to go back to the Sonata study just a little bit when we were participating in that. In fact, studies just seem to go on and on and on. I just had to send in information to the study sponsor for the Sonata study. They're still gathering safety data for the FDA, and they wanted to know some of the information about the probe that we use, the lot numbers, things like that, so they have to track everything. So studies continue to go on, even though it's been over 3 years since we started this study. I'm still sending data in to the sponsor.
Which is very important, because we need to know the long-term outcomes of these procedures. And so, you know, our passion is not only just to do the procedure and help the patient, but yeah, follow them afterwards. Make sure they're okay. Report on what happens in the outcome. And again, that's just lifelong care. So, you know, it's just a wonderful thing that we're doing and helping patients with. And
I have a question. So if you were doing, say, a hysteroscopic or a laparoscopic myomectomy, and you talked about the fibroids that you couldn't reach with the hysteroscopic procedure, can you do the Sonata procedure
absolutely.
at the same time, concurrent with the hysteroscopic myomectomy?
Oh yeah.
So you could do the ones hysteroscopically, and then the ones that are in the wall that you couldn't get to, the wall of the uterus, then you could do both procedures.
Zap them all.
At the same time.
Yep, that's the plan.
Okay.
Zap them all.
So, when we participated in the Sonata study, we were the only site to do the procedure in our office. Most of the procedures were done in a surgery center or hospital-based, and a lot of those, the majority of those, had general anesthesia. We chose to do them in office and
With
use IV
sedation.
sedation. And we used Versed and fentanyl as opposed to propofol, which you might get if you had a colonoscopy, which usually puts you to sleep if you have enough propofol. And so we wanted to gather pain scores from the patients during the procedure. So since our patients were awake and able to communicate with us during the procedure, I would, about halfway through the procedure, I had this little ruler that I would hold up to the patient, and it kind of has like emojis on it. They're like little faces, and they're either happy or sad. And I would ask the patient to slide the ruler to what their feelings were as far as their pain levels. And it was pretty amazing that most of them were on the happy side. I didn't really have anybody on the sad side, so they were all on the no pain. And so that was kind of fun to get that data, which a lot of the other centers didn't get because their patients were asleep during the procedure.
Which is, you know, obviously an option. We happen to have the resources and the equipment to offer it in office. We would not have done it without it being absolutely safe and following all the safety guidelines. So that was very important for us. And what was even more rewarding is that interest we took in minimally invasive procedures with minimally invasive approaches, not hospital-based, and you know, again, way less costly. These are the things that were interesting, because when we submitted our paper to the society meeting, our center was awarded the prize for the best paper at the society meeting for this new instrumentation. Now, there were of course other papers for other new instrumentations, but to be awarded the top prize meant a lot because it showed that, you know, this is the direction people are going. This is the direction the science needs to go. Less invasive, less anesthetic in the office, not in the hospital. And so this procedure, especially if it's just a standalone procedure for women, you know, we can do it here in the office. So you know, we're really excited about this new technology. And I'm really excited, in the last hour we talked about the fact that tomorrow Channel 9 is taking an interest in our Fibroid Awareness Month. And I will be on Channel 9 in the morning at 7:15. Now, at 7 a.m. Channel 9 switches over to National NBC, and then what that does is they go to Channel 20. So please tune in to Channel 20 if you're interested. But you're all getting a preview tonight, so you don't need to worry about it because we're doing everything tonight. They sent some questions in ahead of time. They also had some online questions. Those will be online tomorrow. We've talked a lot about what fibroid tumors are. They're muscle tumors of the uterine muscle cells. Woman generally doesn't always know she has them, but when her periods start getting heavier and crampier, or there's feelings like, you know, there's some kind of mass, or like I didn't used to get up at night to go to the bathroom, but now I'm having to get up once or twice to go pee, and you know, it seems like I have to go pee every hour. You know, those kinds of mass effects can you know, tell a woman when she has a fibroid. You know, the question they asked me was, how do you prevent them? And unfortunately, we don't know how to prevent them. Some smart doctor will win a prize someday. And then the last question was about treatment. We've kind of gone over the treatments already and the benefit of the Sonata procedure. But on the online question, there were some discussions about treatment, and one of the things that, and the reason I think the Sonata procedure is the best thing in 20 years is 20 years ago was the introduction of something called the morcellator. Now, fibroids are big, and when you do the minimally invasive surgery and your biggest incision's only 1/2 inch, and you have a fibroid tumor that's like 4 or 6 inches across, it's not coming out in one piece. Now that's a real important part of minimally invasive surgery. And for a moment, think of the potato, think of the French fries. Now, there are ways to divide a fibroid into smaller portions. One of those would be to take a scalpel and to expand that incision from 12 millimeters to maybe 40 or 50 millimeters. So from 1/2 inch to up to 2 inches, depending upon the size of the tumor. And that allows you then to take a scalpel and divide that fibroid into smaller portions. And I did that between 1990 and 1997. I would put in the scope, I would take out the fibroid, I would then sew the uterus up, but in order to take the fibroid out, I had to expand the incision. And sometimes I could get away with 3 or 4 centimeters, but most of the time it was 4 or 5 centimeters. And in particular, a heavy woman who has a rather you know, thickish abdominal wall, it's a lot harder to keep that incision small. So many of those heavier women had to have even bigger incisions. The bigger the incision, the more pain, the longer the recovery. And in 1997, I was able to do the very first total laparoscopic myomectomy in Denver. That young lady had a 7 centimeter fibroid, and we were able to remove it, close the uterus's suture, and then we used the morcellator, which very rapidly allowed us to remove the tissue. So it means that the surgical time is shorter, the incisions stay smaller, so the recovery is faster and far less painful. That technology I used for about 16 to 17 years, and you know, not all fibroids are benign. And unfortunately, there's this thing called leiomyosarcoma. I'm going to shorten it to sarcoma, and it's when the fibroid is a cancer. Now, people have studied this, and forever, the general teaching has been 99.9% of fibroids are benign. They should be treated as benign until proven otherwise, which is why small fibroids are just watched. You don't need to do a surgery on an asymptomatic fibroid. And so we try and help patients understand these just need to be watched and they don't need anything. But when they get larger and more symptomatic, you know, I've seen the open abdominal surgery, I've seen the longer recovery, and it is so much quicker. And most women will be comfortable with 99.9% likelihood. But the concern is that would this morcellator make the outcome worse if it was an unexpected cancer? And we've known for years that morcellation does worsen the outcome when you run into an unexpected sarcoma at the time of hysterectomy. Now, hysterectomy, you make an open abdominal incision, you remove a uterus, but for years, for decades, and this has been done in other specialties, but for decades, we've been able to use a smaller incision to remove a bigger uterus with the morcellation process. But the studies kind of show that the survival isn't as good. Now, you got to understand, a sarcoma is not good. Stage 1 sarcoma, the 5-year survival rate is about 65% in the medical literature. You know, no other stage 1 cancer that I'm aware of, whether it's ovarian cancer, breast cancer, they all have much, much better 5-year survival rates if you get a stage 1 diagnosis. But these sarcomas, they're a whole different character, and if you're unfortunate enough to have one, you are really, you know, it's not a good thing. And now morcellation, when you divide the uterus up, you're opening the uterus, you're dividing that tumor, and you won't find out for a few days that it's sarcoma. But the literature that's been obtained over the years has indicated in general that this 5 is a little lower, 60% 5-year instead of 65%. And again, you know, if you get a workup and you're already stage 4, well, that's a lot different. And you know, unfortunately, a case occurred where a woman did have a stage 4, and you know, I don't know all the details. I've read about it, and I think, you know, politics are politics, okay? And as one doctor said, hysteria triumphs data. Doctors, physicians, we make decisions based on scientific data. We do not make hysterical decisions. We make logical decisions, but newspapers, they magnify things, and they aren't scientific journals. So when it all came out that, you know, yes, you have to be, you know, advise women that this could happen, what they didn't also look at is the data is when you do a myomectomy, you open the uterus already to take that fibroid out. So you've already exposed to that tumor. If you find a sarcoma, you've already exposed it. Now, whether that's an open myomectomy or a laparoscopic myomectomy, you've already exposed that tumor. So it's not like the hysterectomy where you could take it out all at once. And so you can worsen the outcome if it's a myomectomy because you've already seeded cells into the abdomen. And they've done those studies where they did the myomectomy open, they went and did pelvic washings, they took them back to the lab, and they found these fibroid cells. And the same thing for laparoscopic myomectomy. Now, the interesting thing is once you irrigate, flush out the saline and take that out, those fibroid cells mostly are washed out. So I always irrigate a lot because I really want to be the safest I possibly can. But when the FDA was soliciting information, we reviewed the database, our Advanced Women's Health Institute database, several thousand fibroid procedures. And my experience at that time in 2014 is we are only seeing a sarcoma about 1 in every 2,500 cases. Other authors who did similar reviews with much, much larger data sets said, you know, we think it's about 1 in 17 or 1,800 you're likely to run into it. Primarily because sarcoma is a disease that occurs mostly in postmenopausal women. The average age is around 60 or greater in most studies. So A postmenopausal woman walks in with a fibroid, it's growing, she's having problems, that lady needs to go to the oncologist. A premenopausal woman, the Department of Health and Human Services last December 2017 issued the largest review of fibroids ever, and they confirmed it's about 1 in 1,700 of running into a sarcoma, so less than that 99.9%. And so the bottom line is there are a lot of American women who have a lot of issues like diabetes, high blood pressure, obesity, and we know that open abdominal surgery is much, much riskier. A calculation shows that many, many more women would die from open abdominal surgery than they would from laparoscopic surgery, even when you account for the women who would perish from sarcoma. And we have to make these decisions every day as physicians, and nobody wants a complication, nobody wants to have sarcoma, but you don't want to end up in the ICU with blood clots and end up dying because you had an open abdominal surgery either. So we have to make decisions, we have to do the best we can, and that's based on a lot of scientific data that, courses we go to, workshops we go to, society meetings, because we're all interested in the bottom line, the best outcome for our patients. So the FDA said, this morcellator could make things worse, and you need to share that with your patient. And you probably don't want to be using this in a postmenopausal woman. Certainly, if you think it could be sarcoma, you definitely don't want to be doing that. The problem is that 2 hospital systems out of the 3 major systems in Colorado immediately said we can't use this anymore. And I was invited to participate in the conferences, and the explanation I was given by people who really, I have to tell you, they're not experts, they're just medical administrators. We might get sued. The litigation, the liability, all this is terrible. But what about the patients? What about the fact we're going to harm more women with open abdomen? I don't care. We can't use this. We might get sued. I'm a physician, and I have a tough time harming women because the hospital doesn't want to get sued. And I was very sad that this was kind of pushed on us because it was not a decision made by experts. The societies all came out and said, this is crazy. One hospital system didn't because their doctor said this is the case, and they listened to their doctors. The administration, the bureaucrats listened to their doctors. Center and Health One did not listen to their experts, and I'm not ashamed to name names, not individual names, but hospital systems that their leadership did not, I think, do the right thing, and that's my opinion, and they know it. Over the course of the next few years, I collected the data and I presented it to Centura about how many women were harmed, and I was very disturbed by the fact that many women were harmed by this decision, and what the Centura system did is they said, okay, let's reevaluate. And so their committee of OB/GYN experts couldn't understand exactly why that decision was really made in the first place. I think we all know that it was made to avoid the liability. I mean, we're not going to mince things. They said, yeah, this decision should have never been made. And today I just got the information that, yes, we'll be using the morcellator again in those cases where it's indicated. Now, you have a woman with a huge uterus, and she's morbidly obese, and I guarantee you that the risk of sarcoma is sufficiently low that I would rather take that chance as a physician than I would want to see her opened, because I know her potential risk of serious complications far greater. And so a woman who says, I am uncomfortable with those risks, we do what we need to do. A woman who is comfortable and wants the least invasive approach, sure, she's well informed. It's not just a piece of paper you sign, it's the fact that I spend a lot of time discussing this because I treat my patients like my family, my friends. I had the same discussion with Health One. They are not interested. They went to corporate, not interested, not going to do it. I've asked Channel 9, please help me, help the community, help the women in this community to not have to be forced into these unnecessary surgeries, these more invasive and more harmful potential surgeries. And I hope if somebody's out there and they're listening to this, please, please, Health One needs to change this policy. The problem is now 2 of the 3 major hospital systems are now saying, we understand this complex issue, and we understand that doctors need to be able to sit down with patients and individually determine what's the best course of action, the safest course of action for them. A woman who goes to a Health One physician is not going to be offered those options. She's going to be forced into a less than ideal, a substandard potential for care. And we talk about the standard of care when it comes to medical liability, and it is my opinion as a medical expert that the policy is below the standard of care. And any woman who ends up with an open abdominal surgery she didn't have to, and ends up with a complication that she could have not had, we call those never events, and they're clearly spelled out by the JCO, the hospital authorities, the people that certify hospitals as events that should never occur. And I'm so worried that tomorrow a woman is going to go into a Health One hospital, her doctor wouldn't offer a procedure because the doctor couldn't use this technology, and that woman's going to have a terrible complication. She's going to have a pulmonary embolus and die. She's going to have a massive infection, end up with sepsis and die, because the hospital system does not allow this. And it's wrong. It's absolutely wrong. And as a physician who is advocating for women's health care, the Colorado Medical Society has offered to provide a forum for discussion for them. That was turned down. I still open that offer. If you know somebody who works for Health One, if you please let Health One know there's a serious problem they have here, and they need to stop harming women. And it's just terribly upsetting to see these women harmed when they didn't have to be. And I have to applaud the Centura system for saying, we didn't do it right, but now we're going to do it right now. We're going to listen to our experts, and we're going to do the best thing for women, which is to let doctors and patients individually decide what is best for them. And for some patients, that's not going to be the same as for other women. But I want to be able to take care of each individual patient to the best of my ability to do the safest and most appropriate surgery for them. So I hope you all would tune in on the online part at least and comment. And please share your comments. The more people who chime in, the more people that are out there saying we want doctors to be the ones making the decisions, not hospital bureaucrats who are afraid of liability. Because in the long run, the liability is worse for what they're doing. And if you are somebody who has been harmed by an open abdominal surgery, call me. Call me, because I want to help you be made whole again and as best we can. And if you were a victim of negligence, I want to help you. So it's very important. And this is Fibroid Awareness Month, and we have to make the statements that are very strong about what's wrong. We want to help people with new technologies, with less invasive, minimally invasive technologies that have proven themselves, but it's not right to deny access to FDA-approved technology that could help someone and force them into a more harmful procedure. So for anyone who's listened and anyone who comments and puts it out there, thank you in advance for helping other women, because as a community, we need to come together and help to make the right things happen. So we'll be here next Tuesday, and please, Saturday, it's free care, free consults. We want to help the community and give back for all the good the community's helped us with, and so I'll quit stuttering, and I think I'm getting the flash sign that, it's probably time to kind of pack it up. And was there anything else you wanted to add there, Donis?
Do we have any questions we need to answer before we go? We're all good? So,
Wonderful,
anyway,
wonderful.
so I just wanted to say.
Thank you for questions earlier, Monica. Thank you for identifying yourself, and we really appreciate that. And I hope we've helped women tonight with information.
And our phone number, I guess you probably have it, just want to say it's 303-321-2255. So just call
Saturday
me
the 23rd, 9 to noon.
this coming
Or
Saturday.
more if there's other patients.
Give us a
call us.
Call us. We'll get you on the schedule. You will get a report, not that day because we'll be a little busy. Dr. Moore won't have time to write up a report, but you do have access to that. Even if you don't have fibroids and you wanted to take that report to your doctor, we'll certainly provide that for you within a few days when we get a chance to. So anyway, give us a call. Thanks. Good night.